where do we pediatric cataract, where do we stand now? So we start with the basic evaluation by Dr. Satish Thomas. I have with me Dr. Meena CK to co-chair. Let us go on to the talk. Yes.
So I don't know whether this topic will be required, because I think all of you will be well versed with it. The seniors who are already handling so much of pediatric cataract will have to forgive me, because it's a very basic talk. So what's different about pediatric cataract as compared to adult cataract? Almost everything's different, apart from the fact that there are lenticular opacities in both. So the etiology is different in pediatric cataract as compared to adult cataract. So that will influence the way we work up our patients preoperatively. The anatomy of the eye is different, and that would influence our surgery, the intraop considerations. The way the eye reacts to trauma, to surgery, is very different. So it will have post-op implications. Amblyopia becomes very important in the visual rehabilitation, and it's a growing eye that we are dealing with, therefore importance in the IOL power calculation, size of the IOL, and in the complications. So about etiology, the majority of the cases are idiopathic or hereditary, but we have to rule out some of those other causes, whether they are ocular anomalies or systemic associations, though those are much rarer, but they have to be looked out for. So the ocular disorders that can be associated with pediatric cataract could be aniridia, microphthalmia, PHPV, and the anterior segment dysgenesis syndromes. Systemic conditions where you can get a pediatric cataract associated: Down syndrome, Loewe syndrome, Alport syndrome, the torch infections, hypoglycemia, galactosemia, hypoparathyroidism, and other metabolic disorders. And then we can rarely have steroid-induced cataracts or traumatic cataracts among the pediatric. So we would look for them when we suspect them and investigate accordingly, tailor-made. Coming to the morphology, it's mostly lamellar cataract that we have in the developmental cataracts. We can have the zonular cataract with the spokes or the coronary cataract, all the various manifestations, but mostly it's one zone that's involved. The timing of the surgery: not all lenticular opacities in a child have to be operated. Pediatric cataract has to be taken care of when we know that it is going to interfere with the visual development in the child. And so whether it's going to cause amblyopia and visual development is the most important consideration. A central opacity that would obscure vision, stimulus, and cause stimulus deprivation has to be taken out. Obviously, a unilateral cataract is more amblyogenic and therefore should be operated earlier than a bilateral cataract. So quickly coming to the surgical challenges in a pediatric cataract, the intraoperative factors that make a pediatric cataract surgery a challenge is that we are dealing with a smaller eye, so less space in which to operate. The scleral rigidity is low, and how this would make the surgery difficult is that there would be more frequent AC shallowing, and therefore the capsular excess can keep running out, and we need to suture such a wound because the scleral rigidity is low. The capsule in a child is more elastic as compared to an adult, therefore you need more force to fracture it, and therefore it can tend to run out more than an older capsule. The nucleus is soft. That is one thing that makes a cataract surgery easier in a child, and so we don't need phaco energy most often. And a posterior capsule would need management always, and that's how it differs from an adult cataract, and the need for an anterior vitrectomy also. General anesthesia is always required in a child IOL power calculation is most often to be done on table, so therefore we would have to bring all our machines to calculate the IOL power into the theater. Wound construction, a scleral tunnel for a rigid IOL because you need a big wound. You can probably do a limbal wound for a foldable, but either ways, they always have to be sutured. And high molecular weight viscoelastics are helpful. So this is how an anterior capsulorhexis is done. We begin by fracturing the capsule. And because the capsule is elastic, we need more force. And it tends to run out. Therefore, the force is applied towards the center. So it would be a centripetal force. Try and keep it smaller, and invariably it would end up bigger than what you aimed for. A rough guide would be like in a lamellar cataract like this. Try and keep the size to the margin of the opacity. So the force that you apply is always towards the center. Keep grasping and re-grasping closer to the tearing edge, and that's how you can get a continuous curvilinear capsulorhexis. And that's very important in a pediatric cataract because the anterior capsule integrity is very crucial for long-term centration of the IOL. It reduces the chances of optic capture, tilting, and extrusion into the anterior chamber. Before continuous curvilinear capsulorhexis came, this would be one of the main reasons why a pediatric cataract would have a poor outcome. Lens removal, I think I can skip this because it only requires phacoaspiration. And after that, primary posterior capsulorhexis becomes very important in a pediatric cataract. So we can do it in the same way the anterior capsulorhexis is being done. First, the tear is made with the cystitome, and then we go round and round with the Utrata's forceps. Again, pull it in a centripetal fashion. Try and keep it smaller than your anterior rhexis, but central. And always do an anterior vitrectomy, because if you don't do an anterior vitrectomy, then the after cataract that forms would grow over the anterior hyaloid face. So the vitreous doesn't prolapse like in an adult because it's in a gel form, and that's a good thing. So even if there's no vitreous prolapse, you still go into the vitreous and then remove a bit of the anterior vitreous so that there's no scaffold for the growth of the after cataract. So visual axis obscuration is the most common complication in a pediatric cataract if you do not take care of the posterior capsule. So these are some of the ways in which a pediatric cataract can present later. So the most important thing in a pediatric cataract would be those circles that you see. The anterior capsule, a good circle in the anterior capsule, a well-centered IOL, and a good posterior capsulorhexis. This would ensure that your visual axis remains clear long-term post-operatively. So even when the capsule opacifies, you have the central clear area, ensuring that your visual axis remains clear. You can also do an optic capture to try and ensure that the visual axis remains clear. But if you've done a good anterior vitrectomy, then an optic capture is not necessary. So these are just photographs to show that opacification is invariable and quick immediately post-op, but if you've taken care of it in your primary surgery well, the visual axis continues to remain clear. An IOL insertion into a bag that's already open posteriorly needs care, can be a little tricky. Just make sure that your leading haptic goes into the bag fornix, and then you can direct the haptics into the bag carefully. You can also implant the IOL and then go behind the optic and do a rhexis after you've done the IOL insertion, so that makes it a a little easier. So in the bag, implantation of the IOL is strongly recommended. You could either use acrylic or PMMA, but if you're implanting it in the sulcus, then obviously not a single piece IOL. You could go for a heparin surface modified IOL if required. So thank you for your patience.
On time. Thank you, Dr. Satish. And that was covering the basic evaluation and surgical challenge.